Hello, I'm Dr. Mark Mandel, and it's my pleasure to discuss the treatment of upper extremity injuries in the workplace. In terms of background, I'm board certified in general surgery, plastic surgery, and upper extremity surgery. I've treated and operated upon 18,000 different patients, and I've been an agreed medical examiner on over 10,000 occasions. In terms of my background, I've been around for a long time. I did my original training with Hippocrates, where I worked on the oath. I then spent some time with Maimonides, where we kind of polished the oath. I then went to NYU Medical School, did additional training at Mass General Hospital, University Hospitals of Cleveland, 2 years at the National Institutes of Health, extra training in hand surgery at University of Arizona, and then additional training in congenital deformities at University of Miami. After being the chief of plastic surgery at Case Western Reserve Medical School, I moved to the greater Los Angeles area, where my practice was half workers' comp and half cosmetic surgery. Today I'm going to focus on work-related injuries. As you know, we explore the environment with our hands, so that they're very, very commonly injured. So I'm going to give some examples. So our example is, we have a sous chef, and he's working in a restaurant, and he's busily chopping away, chop, chop, chop. And what happens is he chopped off the tip of his finger. And what I'm going to do is discuss increasingly complex injuries. And as part of this lecture, I did provide everyone with a series of reprints, and they came out of my collection of 3,000 reprints, and I picked out 80 that I thought were very important. I also correlated the type of the injury with how long it takes certain patients to be off work. So our first injury is just the tip of the skin. How do you treat this injury? And the answer is clean it up, wrap it up, and do nothing. These usually heal on themselves, may take a week or two. The patients can then go back to work. Now, if the injury is more extensive, loses his train of thought and chops off a little bit more, and therefore the pulp is missing, this type of an injury won't close on its own. This needs a skin graft. But you can't put what's called a split thickness skin graft on. You need to put a full thickness skin graft, because split thickness skin grafts hyperpigment and leave the patient with a very noticeable deformity, which in many instances has psychological overtones. A full thickness skin graft is harvested either from the side of your hand, or can be harvested from your antecubital fossa, or even your wrist. These take longer to heal. A full thickness skin graft, patient's going to be out of work for at least 4 weeks, and then he'll be partially disabled for, dependent upon the extent of the injury and the type of job he or she pursues for a longer period of time. But what if it's a more significant injury? This time he chops off not only 2/3 of his distal phalanx, but the patient is missing bone. Well, you can't put a skin graft on top of bone, so the bone has to be shortened, and then we need to transfer tissue with this blood supply attached. So that's called a flap. And the most common source of a flap is the adjacent finger. So basically, we're taking skin from the less important part of the long finger, and we're transferring it onto the palm or volar surface of the more important index finger. Now, these fingers are sutured together for usually 2 to 3 weeks, then have to be separated, and someone undergoing a flap procedure is going to be out of work for a minimum of 2 months, and then partially disabled for several months after that. What if the injury is more severe? Well, he cuts off the distal half of the finger. Well, this is too far distal to be replanted, so these injuries at best closed, and actually the patient with this type of an injury can go back to work a lot faster than if he had a flap. Now, if the transfer, the amputation is at this level, due to the degree of sophistication that now exists, 90% of fingers that are amputated can be replanted. The recovery is quite slow. Patients are usually off work after a replantation procedure anywhere from 3 months minimal to as long as a year, depending upon how many fingers are amputated. Now, what if our sous chef slips and falls and slips his hand into a grinder machine and the fingers are chewed up? Those fingers cannot be replanted. For something to be replanted, the only exception being the thumb, the injury has to be a clean cut. So anyone with an untidy injury with disrupted bone, tendons, nerves, soft tissue damage is literally a waste of time to attempt to replant those digits. Now, aside from fingertip injuries, people can have other types of injuries, and the most common is some sort of a slip and fall onto the outstretched hand, or a box is falling and I put my hand up and to stop it from falling. Well, what can happen? Well, the most common type of injury is tendinitis. So itis, as we know, on the end of any word means swelling or inflammation. So for instance, this would be sinusitis, bronchitis, appendicitis. If you look at her hand, our fingers glide through compartments, which is why when we make a fist, the tendons do not bowstring across, but rather go through a series of little compartments that alter the direction the tendons go. Now, surrounding the tendon is a very thin membranous structure called the synovium. So tendinitis is actually a shortening of the term tenosynovioitis, but that's so awkward to say, it's just been abbreviated to tendinitis. The synovium is usually like the emperor's new clothes, you can barely see it. But in tendinitis, what happens is the synovium thickens. So what happens is, as the tendons pass through these compartments, they tend to stick. The most common form of tendinitis is on the back of the hand, named after Dr. de Quervain, and it involves the first dorsal compartment. How do you treat patients with tendinitis? Therapy is not the answer. Any type of tendinitis condition, whether it's de Quervain's extensor carpial narrows tendinitis, flexor carpial narrows tendinitis, trigger fingers, the answer is put it to rest and inject it with cortisone. Cortisone is the main treatment for any type of tendinitis. Now, if the patient is de Quervain's, how many of these patients can be treated conservatively? And what I've done is, if you look at the reference list that I've provided, we have sequential articles, each one of which discusses it. But in de Quervain's tendinitis, 70% of the patients can be treated conservatively. That means job modification, an appropriate splint, usually a thumb spica, and a cortisone injection or two. 30% of the patients at some point in time will need surgery. 90% of the patients with de Quervain's are cured, but a small percentage of them end up with a irritability in what's called the superficial radial nerve. And this is a little nerve that is right next to the tendon. So even if you make a little transverse incision, sometimes that nerve is irritable. If that patient gets an irritable nerve, again, treat it with cortisone, put it to rest. If that doesn't solve the problem, in rare instances, it's necessary to reopen the wound and try to separate the little nerve from the tendon, or perhaps take the little nerve and bury it inside the bone. Now, of course, if you look at your back, the wrist, there are actually 6 compartments. And the most common types of de Quervain's are, of course, the first dorsal compartment of de Quervain's, named after Dr. de Quervain, who lived 200 years ago. And he's associated with Dr. Finkelstein, who noted in 1935 that if the patient grasped their thumb and twisted it in a little finger or older direction, that caused considerable pain. So if you suspect de Quervain's and examine the patient, this is the last test you do, because otherwise you may lose the ability of the patient to cooperate. So Dr. Finkelstein and Dr. de Quervain's are always intimately related to one another in the scientific literature. Patients with de Quervain's who undergo surgery, they usually recover pretty fast, but in a hand-intensive job, they're going to be off for about 4 weeks, and more if they're in a hand job that involves a lot of labor-intensive things like construction. The second most common is extensor carpio-ulnaris tendinitis, which is the tendon on the little finger side of the wrist. Most of those conditions do not require apportionment. They're all either due to a specific injury, most of the time, or continual trauma. Another type of tendinitis are trigger fingers, but trigger fingers are very, very common in diabetic patients. The same treatment is present, although the guidelines are now changing. If the patient is mild triggering, cortisone job modification is indicated. But if the patient is severe triggering, where the fingers are so tightly locked that you really cannot open them without causing a lot of pain to the patients, the new thinking is go directly to surgery. So for severe locking of the fingers, bypass cortisone and go directly to surgery. What other patients can develop trigger fingers? Well, diabetics have a very high incidence of tendinosis. So if the patient is diabetic, this often becomes an apportionment issue, as opposed to de Quervain's and extensor carpi, where it's almost always of industrial origin. What if the patient, in addition to the trigger fingers, also says, well, I have tingling and numbness in my hands? Well, that usually associated with carpal tunnel. Carpal tunnel is a continual trauma claim. Now, it's true, people can get carpal tunnel after a single traumatic event, but it is exceedingly rare. Who would get it? Well, someone whose wrist is fractured, has severe swelling in the carpal canal, can get acute carpal tunnel. I might add that is a medical emergency, and the nerve has to be decompressed. But 99% of the time, carpal tunnel occurs on a continual trauma basis, which from a medical stance is a series of microtraumatic events that alters tissue homeostasis, which means the structures get squeezed, and nerves don't like to be squeezed. Well, how do we decide if the patient has carpal tunnel? Well, they have to give a classical history. Carpal tunnel is characterized by tingling and numbness and night pain. It is usually not characterized by pain during the day. I mean, there may be some discomfort, but classically, the patients will wake up at night because what happens is most of us tend to go into like a fetal position when we sleep. And when you do that, you're basically doing a Phelan's test. And if you palmar flex your wrist within 30 seconds, that goes along with carpal tunnel. That's actually the most accurate of the various provocative tests. Tinel sign is notoriously inaccurate. But if you hold anyone's fingers in a palmar flex position long enough, they're going to go to sleep. So a Phelan's test has to be positive within 30 seconds. Now, what if the patient's findings are equivocal? In the workers' compensation area, it's really important that we have some kind of a objective finding. But carpal tunnel has nothing at all with tendinitis. Tendinitis is swelling of the synovium. Carpal tunnel is a pressure phenomenon. The median nerve of the wrist is surrounded by some special fat called the epineurium. There's a pressure on the median nerve, and that causes the nerve to react, and it causes the nerve to malfunction. So patients complain about tingling and numbness, or my hands sweats funny, or I wake up at night. Well, in the workers' compensation realm, it's really important for us to document what's going on. So we really need a nerve conduction study. I want to let you know that most patients who are in hand-intensive jobs will get carpal tunnel bilaterally, but usually the dominant hand, or the hand that does most of the work, is the one that becomes symptomatic first. So if the patient is felt to have significant carpal tunnel on the right side and some non-specific problems in the left, I would always recommend the neurologist does a bilateral nerve conduction study. Well, what is a nerve conduction study? Well, a nerve conduction study means that at point A, we stimulate the nerve, and then at a fixed distance, and the distance are the same whether you're big, small, tall, short, fat. It's a fixed distance. We record how long it takes to get from point A to point B. Now what happens is, since the nerve compression problems are due to compression of the myelin, the electrical impulse travels down the myelin, but it kind of gets here and it kind of like slows down. So for instance, the normal distal modal latency is less than 4.2, the sensory latency is less than 3.6. So if those values are significantly increased and the patient doesn't improve with a carpal tunnel splint, and has symptoms for a reasonably long period of time, they're usually surgical candidates. What if the nerve conduction study is normal? Well, as we know, to operate upon electronegative patients usually ends up with a very bad result. So here we need to do what's called a provocative test. So we're going to inject a small amount of local anesthetic and cortisone into the carpal canal. Now, the cortisone is anti-inflammatory. It takes the swelling down. The pressure comes off the nerve, and the patient states, well, my hand feels great for 2, 3, 4 days, a week or two, and then it's right back. So that's a positive provocative test. And I would do that in every patient in which the nerve conduction studies are marginally positive or negative. Now, what is the success rate of carpal tunnel surgery? Because you hear terrible things, oh my God, I'm worse, tingling and numbness, my scar is sensitive. 90% of patients are improved by carpal tunnel surgery. Everybody who undergoes a carpal tunnel release is going to have trouble opening a twist top jar or doing a push-up. And the reason is, if you look at your own hands, you can see there's a natural concavity, and that's because the ligament is holding the two portions of your hand to the base of your thenar and hypothenar eminence together. So when you cut the ligament, this springs forward, taking the pressure off the carpal canal. But then the carpal ligament tries to reconstitute itself, but it can't, so it tosses up scar tissue. But the scar tissue is never as strong as the ligament. So therefore, people say I have difficulty opening twist top jars and applying pressure with my palm. That is not a complication of the surgery. The complications usually involve either inadequate decompression of the nerve, doing too much surgery, like trying to strip all the tendons of the synovium. That is absolutely unnecessary. There's no need to do a flexor tenosynovectomy in a carpal tunnel release, which is why an endoscopic carpal tunnel release works just as well as an open. Or what happens is a small nerve called the palmocutaneous nerve, which originates about, since we're in the metric system, 5 centimeters from the crease, gets caught in the scar. The patients have a typical presentation. They have numbness in their thenar eminence, so they have significant pain at the operative site. Now, a lot of times these patients are sent for pain management, and they're erroneously diagnosed as having reflex sympathetic dystrophy or complex regional pain syndrome 1. They do not have complex pain 1. They have causalgia, burning pain, which is now called complex regional pain syndrome 2. There's no need for someone with causalgia to have stellate ganglion blocks. The correct treatment for causalgia, since it's usually an isolated nerve, is to inject the sensitive area with cortisone or local anesthetic, maybe twice, a month apart. And if that does not solve the problem, you have to reopen the scar, and usually that solves the problem. Now, that complex pain 2 is a local problem. Complex regional pain syndrome 1 previously known as reflex sympathetic dystrophy and 30 other names, is regional pain. So as opposed to a specific anatomical area, patients with complex pain develop global pain. So their whole hand becomes painful. And then they have vasomotor instability. So their hand may sweat profusely or may be bone dry. The correct treatment of complex regional pain syndrome 1, and some of the reports are anecdotal, is massive doses of vitamin C, as suggested by Linus Pauling 30 years ago, and aggressive therapy. So if you see someone saying complex pain 1 is suspected, authorization for extensive therapy, I don't mean 3 times a week, for 2 weeks, I mean probably 6 weeks of aggressive therapy, will often reverse a complex regional pain syndrome 1. In addition, you should always do an x-ray of both hands. And patients with complex pain 1 have a very typical pattern. They have what's called juxta-articular osteopenia, which means around the knuckles they tend to lose their calcium. And in some instances, a 3-phase bone scan is indicated. Now, if the patient does have complex pain 1, and I want to let you know that in 3,000 carpal tunnel releases that I've done, I've only seen 3 cases of complex regional pain syndrome 1. 2 of them were corrected, and 1 of them unfortunately went on to the typical end result of basically my hand's like a wounded paw and I can't use it. Complex pain 1, aggressive therapy, x-rays, 3-phase bone scan, and then pain management should be called in, and then they should be authorized to do a series of 3 stellate ganglion blocks to see if they're beneficial. So complex pain 1 is usually what happens after a carpal tunnel release, maybe 3% of the time. I would say true cases of complex regional pain syndrome 1 occur about once in every 200 cases of carpal tunnel release. So it's really rather infrequent. Now, carpal tunnel is multifactorial. You can develop carpal tunnel without having a job. Carpal tunnel can develop idiopathically. Who gets it? Well, long-standing diabetics have 5 times the incidence of carpal tunnel than people without the metabolic disorder. Patients with severe thyroid disease, 5 times the incidence. Patients with rheumatoid arthritis, 5 times the incidence. And the most common cause of carpal tunnel is idiopathic, and occurs from fluid changes as people reach a postmenopausal status. Now, it doesn't mean every patient with diabetes is going to get carpal tunnel. It means there's a greater incidence. If you took 100 normal people, how many in their lifetime are going to develop carpal tunnel? Probably 3%. How many people with long-standing diabetes are going to develop carpal tunnel? Probably 15%. So simply having diabetes or thyroid disease doesn't mean it's not industrial. But if the patient has tingling and numbness in both hands and only uses one hand at work, or has tingling and numbness in their feet and developing diabetic polyneuropathy, then of course an apportionment formula is indicated. So for carpal tunnel, apportionment may or may not be necessary. Now, for every case of carpal tunnel, we have 1 case of cubital tunnel. Cubital tunnel means the ulnar nerve, as it traverses the inside of your elbow, goes around the medial epicondyle, is squeezed, because these neuropathies are pressure problems. It's always amazing to me that if the patient goes to the industrial clinic, the first thing they want to do is exercise the patient, send them to therapy. Well, that's exactly 100% wrong for cubital tunnel. Cubital tunnel is a stretch injury. One of the tests we do for cubital tunnel is we have the patient flex and extend their elbows. And what happens is you're squeezing the nerve against the bone, and that causes the little and ring fingers to go to sleep. So the correct treatment for cubital tunnel is put it to rest. A pillow splint, which costs $50, should be authorized these patients. This is worn at home and at night. It is not worn during the day. if we had 100 patients with cubital tunnel of different degrees, how many are going to need surgery? I would say about 25%, because many of them with mild cubital tunnel will improve by simply relaxing the elbow. And I pointed out several classical studies that are involved with that conclusion. Now, one of the most misunderstood aspects is thoracic outlet. And here's one of the problems, because a lot of the plastic surgeons now are not trained in general surgery. A lot of them, hand surgeons, even though they're orthopedics, only examine the hand, wrist, maybe they examine the elbow. Nobody seems to examine the shoulder. And when you examine these patients, it's really important. Where is the site of compression? Is it the wrist? Is it the elbow? Is it the outlets of the thorax? Is it the neck? So for every 100 cases of carpal tunnel, we have 10 cases of cubital tunnel. I would say for every 100 cases of cubital tunnel, we have 1 case of thoracic outlet syndrome. And I want to let you know that 5% of the cases of thoracic outlet are arterial, 5% are venous, and that's where all these tests came in. You know, the right maneuver, the Adson maneuver, the Roos maneuver, costoclavicular maneuver. Probably 90% of people have one of those tests positive. Who gets an acute vascular or venous thoracic outlet? Well, people that toss off the handlebars of their motorcycle and land onto their shoulder, and they have compression of the area. But that's rather unusual. Most of the cases we see in workers' comp are called disputed thoracic outlet. A nerve conduction study is almost always negative in disputed thoracic outlet. Well, who gets thoracic outlet disputed? Well, most people who develop it get it in by doing data entry. And the reason is, when I was in surgical training after I left Maimonides and Hippocrates, I went to the surgical office, and all of the secretaries, aside from being well-dressed and perfectly groomed, are sitting on their IBM selected typewriters, perfect posture, neutral wrists, and we hardly ever see anything in the form of neuropathy. Even carpal tunnel was relatively unusual in those days. But now with a computer, we're much more relaxed. You know, we're kind of like leaning forward and relaxed. Well, what happens is when you do this maneuver, you're actually doing a costoclavicular maneuver. You're stretching and squeezing the various structures, because outlets of the thorax means the nerves are compressed somewhere between your neck and your armpit. So this area here, this is the outlets of the thorax. How do you treat thoracic outlet? Therapy. Changes in the workstation ergonomics. I would say it is unusual in disputed thoracic outlet to undergo surgery, unless, of course, you go to an institution where one of the fortes is a treatment of thoracic outlet. So, for instance, if you went to UCLA, they have some experts in thoracic outlet, and I get to see them as the AME. And I've done thoracic outlet surgery many years ago. And to treat thoracic outlet, you have to make a bigger area. So that means first you have to transect some muscles, because these scalene muscles often compress the structures. You have to remove a rib. Now, if you ever bruised a rib, you know how painful it is. So you can imagine taking out a rib with bone cutters. That is a pretty uncomfortable experience. So thoracic outlet surgery rarely occurs in the workplace unless there's some specific injury on a work-related basis, like a construction worker. But the incidence is quite unusual. Now, our chef is back, and this time he doesn't cut his finger, but he slips and falls, and he goes to industrial clinic, and he's diagnosed always with 2 diagnoses, regardless of what happens. It always says sprain strain. So does anyone know what sprain strain means? Well, they're not the same thing. A sprain means that the ligament holding two bones together is interrupted. Now, there are different grades. There's like some microscopic interruption, in which may be swollen and red. There's a partial tear, and there's a complete tear. A strain means that the muscle and tendon attached to the bone is injured. So here, if we look at the wrist, the most common injuries are to the scapholunate. So this is scaphoid of the lunate. Now, I've seen many cases undergo scapholunate repair, and nobody bothered to look at the other wrist. The reason why I'm pointing it out, the patients weren't improved by the surgery. 10% of people have tears in their ligaments that are natural or lax ligaments. So if you suspect a scapholunate injury, it's always necessary to have the patient obtain what is called a clenched fist view. Because if you clench your fist, you can feel like the bones are kind of trying to pull apart. And if the patient has a ligamentous tear, it's going to become obviously, even if it's a partial tear. But a lot of people have widening on both sides. So it's very important, any kind of a internal derangement of the wrist, before you do MRIs and MR arthrograms, to do a clenched fist view. Because a lot of times they just do a flat view like this, and there's no stress on the ligaments, so it comes back normal x-ray. Then what happens, because the patient has wrist pain, and they order an MRI. Well, there's another $2,000 plus, and then that comes back equivocal. So they order an MR arthrogram. Well, as you know, by the time these things are authorized, the patient's been out of work 3 to 4 or 5 months, and it still is in pain. So a recent article by Dr. Cunningham offered a very simple solution or an algorithm. He said, what is the differential diagnosis? Is the problem outside the wrist, that we're dealing with tendinitis, or possibly a strain, or is a problem inside the wrist and we have a strain or a ligament tear? He said, all we have to do, and I've done this for years myself before the article was published, is inject the wrist, inside the wrist. If the pain goes away, we know the problem is inside the wrist. If the pain doesn't go away, what do you anesthetize the wrist? You know, it's probably outside the wrist. Well, if the pain is inside the wrist, and the patient gives a history and has some supportive plain films, there's no sense getting an MRI and then an MR arthrogram. You probably should go directly to an arthroscopic assessment of the wrist. First of all, MRIs are not 100% accurate. The MRIs are only accurate 80% of the time. The MR arthrograms may be accurate 90% of the time. But when you look in the wrist through an arthroscope, it's accurate 100% of the time. And not only that, the patient is treated more expeditiously. And then depending on what the problem is, it can be fixed. Now, in addition to the scapholunate, the next most common type of injury is to the what's called the triangular fibrocartilage complex, which is a fibrocartilaginous piece of material that kind of holds the distal radius, the ulnar, and the carpal bones together. Now, how common it is to have a tear in your TFCC? It's very common. Indeed, in a study done by Dr. Chung, he pointed out that 30% of patients under the age of 45 have tears in their TFCC. The reason why I'm pointing this out is that I've seen many cases as an AME in which the person has identical findings on both sides, but they only look at one wrist, has a tear, patient has no complaint about pain on the little or ulnar side of the wrist, and he undergoes an operative procedure, and of course, they're not helped. So it's always important to quantify the diagnostic studies with the patient's clinical presentation. If the patient doesn't have ulnar-sided wrist pain, and his pain is on the thumb side, there's no sense going in and repairing the TFCC. It's probably just a normal variant. So one always has to say, what is the patient telling me? Let's listen to the patient. Because as Osler said at Hopkins 150 years ago, God gave you eyes, ears, and hands. Use them in that order, which means if you listen to the patient, he can often tell you the diagnosis. Hey, tingling and numbness and night pain, carpal tunnel. Hey, I can't pinch and hold on to objects, I'm clumsy, Decorah veins. So listen to the patient, correlate his presentation or her presentation with the diagnostic studies, and then operate appropriately. Now, one of the most confusing areas of treatment is epicondylitis. As opposed to tendinitis, because every form of tendinitis is treated with cortisone, there is no indication that cortisone is of any value for epicondylitis or tennis elbow. And the reason is there is no itis or inflammation in epicondylitis. Many years ago, before we had an electron microscope, we thought tennis elbow was just like tendinitis of the wrist or fingers. But tennis elbow is actually a microscopic avulsion of the extensor muscles off the bone origin. So epicondylitis is actually a strain. And strains do not improve with cortisone. How do you treat epicondylitis? Well, first, it's very annoying. I've had it myself on both sides. Would I let anyone operate on my elbows? Absolutely not. 85 to 90% of the time, and it takes a long time, epicondylitis will gradually heal on its own, regardless if you do massage therapy, physical therapy, occupational therapy, acupuncture, or anything else you can think of. But cortisone is not the answer. Now, about 10% of patients need surgery. And how do they fare in the workers' compensation realm? Well, 60% of patients are much better. 20% of patients they're not better, but they're not worse. And 20% of patients are actually worse after surgery, because sometimes we damage a little nerve called the lateral antebrachiocutaneous nerve, and sometimes the repair doesn't hold. Now, emerging in the last decade is the use of platelet-rich plasma. Now, I read an article 25 years ago by two surgeons in Washington, D.C., and they said, well, we've been treating our patients with tennis elbow with blood. So we draw blood out of one arm and we inject it into the elbow, and that sounded really like something interesting. So I did it a few times. And, about, I think, 6 of the 8 patients got better, and 2 didn't get any better. But I don't know if they got any better because epicondylitis goes away on its own or the blood helped. But what's happened is, the thought pattern was, well, if whole blood helps, let's take out a lot of blood, spin it down, let's get rid of the red cells, they're not helping any, get rid of most of the serum, and in that concentrate we have the platelets, the white cells, healing elements circulating, little microparticles with proteins on them, and we'll inject that, and that'll cure everything. And now there are platelet-rich plasma injectable sites for every anatomical part, not only musculoskeletal, but want to regrow your eyebrows, want hair growth, want your face to be rejuvenated. But I don't know about the facial part, but it's the editor-in-chief, Dr. Mallon of the Journal of Shoulder Elbow Surgery, states there's no evidence platelet-rich plasma is really of any value. There have really not been any controlled scientific experiments. It's all anecdotal. But the one area in which it seems to be beneficial is epicondylitis. But if you think injecting 3 cc's of platelet-rich plasma into someone with bone-on-bone knees is going to solve the problem, I think you're really in fairyland. There's no evidence of any value in treating patients with rotator cuff disease, but I see numerous recommendations. Oh, the patient needs platelet-rich plasma to help it heal. Well, to help it heal, you should treat the patient post-operatively appropriately. So in terms of platelet-rich plasma other than perhaps epicondylitis, there's no scientific evidence of any significant value. Now, there is a new procedure described by the surgeons at Mayo Clinic, who are kind of a very pioneering group, and they found that special type of ultrasound is beneficial. So that's called a 10X procedure. This is an outpatient procedure. It takes about 20 minutes in your office, but you need the special probe. It's done under local anesthesia. And like any procedure, the people who advocate it say it's wonderful, but it does appear to be of some value. But again, the bottom line for tennis elbow, leave it alone, and 80 to 90% of the time it'll heal itself. Now, I don't have time to go into wrist fractures, but our injured worker slipped and fell, and he strained his ligament. Well, what happens is, goes to Concentra or some other clinic, and they examine the wrist, because that's where the most pain is. It's like if you're in a motor vehicle accident and you get rear-ended, and the seatbelt slams against your chest, and you have a lot of pain there. And then 3 days later you say, my neck is killing me, because you have an acceleration-deceleration injury. Well, what happens is they focus on the fractured wrist or the severely ligament-compromised wrist, and they forget about the patient's shoulder. But if you think about it, if you fall onto your outstretched hand, sufficient force to break your wrist to tear a ligament, I mean, these ligaments are strong. Where does that force vector go? What's transmitted up to your shoulder? So about 10% of people with significant wrist problems of that nature, slip and fall, end up with a shoulder problem as well. And the reason is, well, if you look at the shoulder, it's an inherently unstable joint. The shoulder looks like a golf ball sitting on a tee, which means the surface of the top of the humerus is only about a third of the surface of the glenoid fossa, or the inside of your shoulder blade. And there's really not much holding it. It's like any joint that moves a lot, your shoulder, your thumb, your hip. They're prone to injury, as opposed to, say, your fingers, where the proximal interphalangeal joint only goes up and down, doesn't go side to side. So the person slips and falls, and the force vector results in the head of the humerus being slammed against the glenoid fossa, and if the surface of the glenoid fossa, called the labrum, is injured, the patient has a labral tear. In some instances, the patient can sustain a dislocation, but those, again, because the shoulder is not protected, 95% of the dislocations are anterior, because it's hard to posterior dislocate because your shoulder blade's in the way. But if you had 100 shoulder injuries, probably 3% would be dislocations, 20% would be labral injuries, and the lion's share would be rotator cuff disease. The treatment for labral and rotator cuff injuries is therapy. The goal of therapy is to strengthen the scapulothoracic stabilizers and keep motion in place. Cortisone is used, and then if the patient doesn't improve, an MRI is indicated. But you have to remember that as we grow older, all of our MRIs in the joints that move become unable, because if you look at the insertion of the rotator cuff on the head of the humerus, is fibrocartilaginous, and as we grow older, water leaches out, tends to fragment. In a classical study out of New York City, in which patients with no shoulder complaints in their history, followed by competent doctors, underwent autopsy for some other reason, they found out that 60 to 70% of the patients had either complete or partial tears, because it just wears out. So when you have an MRI of the shoulder, you have to say, is this an old problem or is this a new problem? And sometimes you'll do an MRI on the other side and you see abnormal findings, but unless the patient's findings correlate with the MRI, they're not a candidate for invasive treatment. So studies indicate that 80% of patients with severe impingement or rotator cuff tendinitis will improve with conservative care, and 20% need surgery. Almost all of the surgical procedures will be done arthroscopically. And in the past, almost everyone had what's called a Mumford procedure, or they resected the end of the clavicle. But Dr. Cofield, who was the president of the American Society of Shoulder and Elbow Surgery, chief of orthopedic surgery at Mayo Clinic, and one of the best known experts in shoulder, says, really don't need to do a Mumford procedure anymore. The reason for pointing this out is when you read the operative report, they always say, we did resection the clavicle, but they didn't really do a resection of the clavicle. They did an acromioplasty. But if you do a Mumford procedure as you know, is a whole prison impairment of 6%. So there's a big difference between shaving off an osteophyte on the undersurface of the acromial process and performing a Mumford procedure. Now, sometimes the surgery is extensive, and if the patient goes on to develop arthritic changes or instability, then a simple arthroscopic procedure is insufficient, and you really have to go to complex procedures like using a graft jacket, or the last few years, the capsule reconstruction. And sometimes if those surgeries are unsuccessful, the patient needs what's called a total reverse arthroplasty. Originally, it was felt that only people over 65 should have that, but now the guidelines have been softened, so you see people in their 50s. The problem with replacing the entire joint, especially upside down, a reverse arthroplasty means that instead of the ball being here, the ball is here, and the smooth surface, instead of being here, is now here. So you reverse the anatomy. But the problem is these joints have not been in place in any significant number of years for more than maybe 4, 5, 6 years in a large number of patients. So if someone has a joint replacement at 55, the question arises, how many more times, if he's going to live to 85 or 90 or longer, is that going to have to be repaired? So I think one has to use their discretion. Now in shoulder injuries, apportionment is always important. First, diabetics, much higher incidence of frozen shoulder, heal slower. You should never do elective surgery on a diabetic patient if their HbA1c is greater than 7.5. You're just asking for trouble. Obesity, these patients do poorly with shoulder surgery. Smokers, absolutely do not operate on someone who's a heavy smoker. Not only for the shoulder, but if you're doing a bone graft procedure or fusion of the wrist, smoking will end up in a non-union. And the reason is smoking shunts the blood from the little arteries directly into the little veins. To remove the metabolic byproducts that we produce, the blood has to go through the capillary network. But if you're shunting the blood from artery directly to vein, the lactic acid and other metabolic products simply build up. So healing is incomplete. I'd like to conclude by thanking everyone for listening. Be more than willing to answer any questions. I do think one of the most important things to remember is that there's no correlation directly between the diagnostic study and unless there's a direct correlation between the diagnostic study and the patient's clinical presentation, surgery is not indicated. We have to remember that significant number of people have abnormal MRIs. And simply having an abnormal MRI doesn't mean there's an impairment. That is always important to examine both upper extremities in any type of upper extremity injury. That apportionment is definitely necessary in any type of a continual trauma claim, especially if the patient is diabetic, has thyroid disease, or any sort of an autoimmune or rheumatologic disorder. And if the patient is a smoker, the surgery should be delayed until that person stops smoking for at least a week or 2 weeks before surgery, and probably forever afterwards. Thank you so much for listening, and I appreciate your time and would be more than willing to answer any questions.